Okay, so our next, is this working? Yep. Our next speaker is going to be Dr. Nick Hatamiya. So he is going to talk to you guys about elbow, hand, and wrist injuries. So the upper extremity of Dr. Luke's talk. A little bit about Dr. Hatamiya. He is one of our primary care sports medicine physicians at UCSF. He earned his medical degree from Western University of Health Sciences and did his residency in family medicine at Stanford University. There, he served as chief resident before going to UCLA to complete his fellowship in primary care medicine. He serves as the team physician for Academy of Art University and the Oakland Roots soccer team. Go Roots. He also runs the fellowship program for the UCSF Primary Care Sports Medicine and can be found doing research on applications for digital health technologies in patient care in interventional ultrasound. Fun fact for Dr. Hatamiya, because you're all waiting for that, his Spotify age this year was 67. For all the parents out there, I still don't know what this means, but it is what it is. I'll give him one additional fun fact for today, which is it's his birthday. So everyone say happy birthday to Dr. Hatamiya. Thanks for being here on your birthday. We know it's your present, so... Yeah. Are you 67? Is that how old you are today?
Not quite.
You look great for 67 if that's the case. All right, everyone. Dr. Hatamiya, it's all yours.
Oh, got it. All right. Well, good morning, everyone. Thanks for joining us. Hopefully you've been enjoying the course so far, and thanks, Danny, for the kind introduction. It is true, my Spotify age was indeed 6'7". However, although it is my birthday, I'm not quite that age yet, although I am a year older. Today I'm going to be talking to you about the top 5 upper extremity problems in primary care. And when I got asked to give this talk, I was like, oh my gosh, there's so many things for the elbow, hand, and wrist. How could I possibly go through all of those? And I came to the conclusion that I cannot go through everything that I wanted to talk about, but hopefully what I will highlight here are some really common things that you'll be seeing in your clinic, or if you haven't seen them, you will definitely be seeing them. I have no relevant disclosures, and my objectives for today, by the end of this talk, I hope you become comfortable diagnosing common upper extremity musculoskeletal conditions that present to a primary care clinic, develop a framework to assess these upper extremity injuries, and then feel comfortable as well as confident performing a physical exam for these. So as I mentioned when I was brainstorming what to really talk about, I broke it down into different regions of the upper extremity. Luckily, I didn't have to talk about the shoulder. You're going to get a talk next by my colleague, Dr. Feely, that's all about the shoulder. So we're just focusing on the elbow, wrist, and hand. And at the elbow, I thought about common things I saw when as Danny mentioned, I trained in family medicine, what I saw a lot in my family medicine clinic, but also what I still see in my sports clinic. So these were the top things that I thought about. So lateral medial epicondylopathy, cubital tunnel syndrome, and then bursitis, specifically thinking about olecranon bursitis. Down at the wrist, I thought I saw lots of carpal tunnel syndrome, as well as Dekkervain's tenosynovitis, ganglion cysts, and then fractures, whatever those may be, either the distal radius or the ulnar styloid. And then down at the hand, there's a lot of different things that you can see at the hand, but the most common things that I saw, trigger fingers, also known as flexor stenosing tenosynovitis, CMC arthritis or carpometacarpal joint arthritis, and then Dupuytren's contractures. That's still a whole lot of different things to go through. So really what I'm going to focus on during this talk are these things that are bolded here. And I think I have about 50 minutes to do both the talk and the physical exam. So I'm hoping to spend around 30 minutes through my slides and then 20 minutes going over the physical exam. And then obviously we'll have some time at the end for questions. So feel free to put those in the app. All right, we'll jump right in. So we'll start with lateral epicondylopathy. So lateral epicondylopathy is an overuse tendinopathy of the wrist extensors as they insert onto the lateral epicondyle. And so what you're seeing on the picture is a diagram of the elbow, and then you can see where that lateral epicondyle is, and then those wrist extensors running and inserting right onto that lateral epicondyle. The pathophysiology is really microtearing that involves mostly the ECRB, or the extensor carpi radialis brevis. And one thing I think that's really nice when you're seeing someone that's complaining of some sort of upper extremity injury is that they can often localize where they're having their pain really well. So unlike the shoulder, where sometimes it's kind of like a black box unless it's the biceps or the AC joint, with an upper extremity injury, usually they're pretty good at pointing to where it hurts. So for lateral epicondylopathy, for example, they'll usually point right to that lateral epicondyle. And you can kind of feel on all of yourselves where that lateral epicondyle is, which is that bony prominence on the outside part of your elbow. So often they'll point there and say they have tenderness over that area. This occurs in around 1 to 3% of the population annually. And as many of you may know, we call it tennis elbow because that's how it was originally described, although it is not as common as we think in tennis players. So only around 5 to 10% of tennis players have this. And it can be occupational related. And typically we'll think about people either in their 30s, 40s, or even older that may have symptoms related to this. As I mentioned, symptoms are really pain and discomfort that localizes right onto that lateral epicondyle. And so that picture is similar to the one that I had on the prior slide, but now we've just added a real world example of what you'll see in your clinic and kind of where the patient might point to where they all have their symptoms if they do have this. It can radiate down the extensor tendons, and sometimes they'll say it's right here, but it may be more diffuse kind of right around that whole extensor area as those wrist extensors insert onto that lateral epicondyle. Typically, it's worsened by wrist extension. So as I mentioned, it's that ECRB that causes the discomfort. And so as you do the action of those muscles, they'll often complain of discomfort. One thing that they may mention to you or even show you is that when the wrist is fully extended, or their elbow is fully extended, as they barely extend their wrist, sometimes that'll be very aggravating for them right over that lateral epicondyle. And we'll talk about my next slide what that exam maneuver is. In some cases, they may complain of grip weakness. That could be secondary to pain because as you grip things, it can often be painful as you activate those wrist extensors. And they may complain of difficulty grasping or lifting items. So on exam, the classic test that we do is called Cosen's test. And as I mentioned, this is basically just reproducing the action of the muscles that insert along that lateral epicondyle. So for this, what you'll have them do is I like to have their elbow fully extended, and then you're gonna have them either actively or even passively, you could do this, extend their wrist. Now, if they have a really angry and upset tennis elbow, sometimes just getting into this position might be enough to aggravate it, so then I'll just stop there. But in some cases, as they just even slightly extend at their wrist, they'll say, oh, I have lots of discomfort right over that area. So that, combined with just tenderness over that area, makes me think that it's lateral epicondylopathy. Another test that you can do is called the resisted long finger extension test. So for this, what you'll have them do is have their wrist in slight extension with their long finger down in flexion, and then they're gonna resist extension as they, you're gonna resist them as they try to extend their long finger up. This activates part of the wrist extensors. Also, this can be used to look for something that's called radial tunnel syndrome. Radial tunnel syndrome can often be confused with lateral epicondylopathy, but I'll say radial tunnel syndrome is more of a diagnosis of exclusion. For radial tunnel syndrome, that's where the radial nerve is getting entrapped at some point in time. They may complain of more vague pain that's in the forearm. It won't really localize to that lateral epicondyle. It might be a little more distal to that. So if they have some tenderness that's more over the wrist extensors kind of in the forearm, and you're like, that's not where Dr. Hatamiya said lateral epicondylopathy should be, then maybe think about radial tunnel syndrome, but again, a diagnosis of exclusion. So for treatment, there's a lot of different things that our patients can try, which is, I think, a good thing. So obviously rest and activity modification, specifically if it's occupational related, asking them about what they're doing and then trying to see what might be aggravating it. If they can modify that in any way, can be quite beneficial. Bracing, there's kind of two different things that you can think about. The one that's depicted on the screen there is a counterforce brace. You may have seen some tennis players or even people come to your clinic with it. It's essentially just a compressive brace that they'll place there to kind of offload the insertion or the forces or redirect the forces of that muscle as it inserts onto that lateral epicondyle. And then some people will even put the wrist in a brace to prevent them from going into wrist extension. And I think that's helpful if they're sleeping at night in funky positions. They can wear the wrist brace. It's they're sleeping, so it hopefully isn't too disruptive to their daily life, but can really offload that extensor mechanism there. Non-steroidal anti-inflammatories, either topically or orally, physical therapy. And then injections, there's a lot of different ones, and I'll talk about them a little bit more in my future slides, but steroids we've used, which I think we've kind of shifted away from using as frequently as we've done in the past. And then some emerging things, which includes PRP or platelet-rich plasma, as well as needling, percutaneous needle tenotomy, where you use an ultrasound to visualize where that tendon inserts, and then you fenestrate the tendon with a needle. Shockwave therapy, as Dr. Luke mentioned previously, is another emerging thing that we've been using, and then surgery kind of as the last resort. So what about those steroid injections? And that's something that, let's just see a show of hands for those that do injections. How many of you have done injections for tennis elbow using steroid before? Yeah, okay, a good amount. So steroid is a strong anti-inflammatory, and we know that it can be helpful, but some recent studies show that the improved outcomes from this are relatively short-lived. So often patients will come in, they'll have a lot of discomfort, they want to get out and be back on the tennis courts or be at their job, and they're desperate to get some relief. But when you do a steroid injection, they'll have really great relief for a couple of weeks, but often what happens is it comes back and they have relapsing pain that is often a lot worse than what they came in for. And we know from our studies that steroid injections really have no lasting benefits beyond 3 months. So at least I know a lot of our hand surgeons have shifted away from doing steroid injections if they can avoid it, and then try other things, which I'll talk about in my future slides. I'm kind of in the middle. I counsel my patients quite a bit on this, and I tell them this. I say, we can try a steroid injection. It might help in the short term, but it's probably going to come back and won't be beneficial in the long run. That'll save you from getting the message, a month later from your patient on MyChart, whatever EMR system you're using, saying, hey, I felt great after the injection, but now it's just really killing me. What can I do next? So I really take the time to counsel if they're interested in a steroid injection. And often they may have gotten one previously if they've had it on one side, or they may have a family member or friend who's gotten one and gotten relief. So I think there's still a lot of people out there that want a steroid injection. Now, those can be fine to do. I mentioned platelet-rich plasma. So what's the data on platelet-rich plasma? So platelet-rich plasma, I think as Dr. Luke may have mentioned, but it's where you draw your blood, spin it down, take out this platelet-rich layer, and then inject it into whatever body part. This was a meta-analysis and systematic review of several studies that looked at 11 randomized controlled trials, around 730 patients that received both PRP and steroid. What they found was that both were effective. The steroid had shorter-term benefit, but in the long run, PRP provided longer-term benefits. It is important to note that in this systematic review and meta-analysis, the PRP concentrations were different, and we think that the dose of PRP matters now. That can be a whole talk in and of itself. This is a paper that was published by my colleague in our course faculty, Dr. Bill Berrigan, who's giving a talk, I believe tomorrow, specifically on orthobiologics. So for those of you that want to take a deeper dive into that, I encourage you to attend his talk, as more to come. What about other therapies? So beyond PRP and steroids, this was a recent study that was published a couple of months ago in AJSM that looked at 200 patients that were randomized into 4 different groups. So there's one group that got physical therapy, one group that got shockwave therapy, which is, I tell my patients, kind of like an industrial version of those Theraguns. Have you all seen those massage guns that people have? So it's kind of like that, but not as pleasant. It's actually quite uncomfortable as you do that. PRP and then prolotherapy. Prolotherapy is using dextrose with some sort of anesthetic or saline and injecting it into the area. And they followed this cohort out for 2 years, so 24 months. And what they found was that all groups had clinically meaningful improvement, but they noted that the PRP and the prolotherapy group had better clinical and functional outcomes compared to the shockwave and the physical therapy group. So, my takeaway from this is I think that aside from steroid, there's a lot of other things that you can try that will be beneficial, which includes physical therapy, because all of these groups had clinically meaningful improvements. All right, so we made it through the lateral epicondylopathy. Now we'll just switch sides and talk about the medial elbow and go through medial epicondylopathy. Medial epicondylopathy is very similar to the lateral side. It's overuse tendinopathy of the wrist flexors as well as the pronators as they insert onto that medial epicondyle. So this should look like a familiar photo, except for looking at the lateral side. Now we're looking at the medial side, and you can see where those wrist flexors run and insert onto that medial epicondyle. This is actually less common than tennis elbow. So many of you may have seen lateral epicondylopathy in your clinic, but less commonly see it on the medial side. This, unlike tennis elbow, is called golfer's elbow, but similar to tennis elbow, we don't see it a whole lot in golfers either. We do see it in men more than women, around 30 to 50 years old, and it's caused by forceful activities or repetitive motion that involves wrist flexion. The symptoms, again, will localize right to that medial epicondyle. So with one finger, they'll often point to the inside part of their elbow. It can radiate along those wrist flexors and is worsened by any activity that involves pronation or wrist flexion. And again, they can have grip weakness secondary to pain. The treatment is very similar. So if you've mastered lateral epicondylopathy, you're also a master of medial epicondylopathy. So thinking about non-steroidal anti-inflammatories, activity modification, bracing, the counterforce brace can also be beneficial. Physical therapy, you can try all of those different interventional things that I mentioned on the previous slide, although I would just be extra cautious on the medial side because we have the ulnar nerve which runs through the cubital tunnel there. So just make sure that you're not going to inject into the ulnar nerve on that side. The ulnar nerve you can all palpate, and I'll show on the live on screen, but as you all are sitting there, if you feel on the inside part of your elbow where that bony prominence is, and you just go a little bit posterior to there, you'll feel this little dip. And then if you kind of either rub or tap over that spot, you might get electric shocks going down into your ring or pinky finger. That's your ulnar nerve, or the funny bone that we call. So just make sure you're not doing an injection into that spot. The way to really identify where the epicondyle is if you're having a problem is to activate those muscles. So for the medial side, if you do wrist flexion, you can feel all those muscles running and inserting around onto that medial epicondyle, so that can give you some extra feedback that you're really in the right spot there, and that's where your patients will often have some discomfort. Great, I can see everyone sitting here doing these motions. I know you're all awake. Okay, so we'll move from the elbow going down to the wrist and talk about carpal tunnel syndrome. As many of you know, carpal tunnel is compression of the median nerve as it runs under the transverse carpal ligament of the wrist. So that photo, which I'm sorry, it might look a little small there, is a cross-section view of what the carpal tunnel is. So you can see the contents of the carpal tunnel and then the walls of the carpal tunnel on the side. The median nerve provides sensory and motor to the hand. So for sensation, we think about the thumb, index, and long finger. And then on the volar side, it provides it to the radial half of the long finger. And then it swoops over on the dorsal side and just does the tips of the fingers. And then for the motor, it does several things, but mostly wrist and finger flexion and thumb opposition. And a flashback to your anatomy class, if you might remember the mnemonic MEDLOAF, so median nerve does the loaf muscles, which are the first and second lumbricals, the opponent pollicis, the adductor pollicis brevis, and then the flexor pollicis brevis. This is the most common compressive neuropathy of the upper extremity, and it impacts around 15% of the general population. As a show of hands, if you're comfortable, how many of you have experienced carpal tunnel syndrome before? All right. Okay, I'd say about 15% of you all in the crowd, so a good representation of our stat there. Women tend to have it around 40 to 60 years old, and it's more prevalent in certain conditions. So those that have diabetes, obesity, hypothyroidism, it can be associated with pregnancy, and then certain occupational exposures that we think about, specifically with computer use and typing or mousing. The symptoms can be a lot of different things. So you can get the classic numbness or tingling, but sometimes they just have pain and paresthesias that might wake them up at night. So often my patients say they have like a burning sensation that they feel in their hand. It may not be described necessarily as pain or pins and needles. They'll say they have burning, and they have to wake up at night to kind of shake their hand out. That makes me think they might have carpal tunnel syndrome. And then it's worse with any sort of activities that involve wrist flexion. So I think about driving or phone use these days, all of those different things. And that's why at night sleeping, our flexors are stronger than our extensors, so we often sleep in that flexed position. And so that's why at night their symptoms may get a little bit worse. In more severe cases, they may start complaining about weakness in the hand or clumsiness, like they're dropping items or they can't button their shirt as well, or even more severe cases, they can't distinguish certain things like 2-point discrimination. So like if they have a nickel or a quarter in their pocket, they can't tell the difference between those. This was a study that looked at the presenting symptoms of those that had electrodiagnostically confirmed carpal tunnel syndrome. And you can see by far the most common symptom was numbness, so 94% of them, followed by pain in the median nerve distribution, and then weakness was much less common. So it gives you kind of a good sense of what your patient might say to you when they're coming in and what might raise their suspicion as to whether or not they might have carpal tunnel syndrome. On physical exam, just by inspection alone, that can be really beneficial and allude you to what you might think is going on. So in this photo here, you're looking at the volar aspect of 2 hands. On the picture that's on the right, you can see there's some thenar atrophy there. So just looking at the muscle bulk beneath the thumb, you can see that that muscle's atrophied. An easy way to do this, and I'll show on the physical exam, is to, I have the patient make a little L shape with both hands like this, and then bring their palms up. And if you do that, that really highlights that muscle bulk there. So it's an easy way to have them do it. If you tell them to do like palmar ab or adduction, they'll look at you like, what are you talking about? So I just say make an L and then bring it up, and then you can see that muscle bulk a lot better. Because sometimes this can be really subtle to see, and if their palms are straight up, you might not be able to appreciate it. And then there's several tests that we do. Durkin's compression test is one. That's where you're essentially putting pressure or compressing right over the carpal tunnel, and you're holding it there for around 60 seconds to see if that reproduces any of their symptoms. Phelan's test is another one that you do, so you're just having them put their hands into wrist flexion. I actually don't like this photo. I probably need to change that in my talk. So this is a modified Phelan's that is showing. When I do Phelan's, I actually like to have them with their elbows extended and then have them flex at the wrist, because if their elbows are flexed, that can be a confounder. So the classic way it was described is by having their elbows extended, and you have them sit there like this in clinic while you chart or do something for 60 seconds and then see if it reproduces any of their symptoms. And then finally, you can do what's called a Tinel sign. That's really tapping over that site where the carpal tunnel runs. I like to use broader contact. There's lots of debate. Should you use 1 finger, 2 finger, 3 fingers? I essentially just use as many fingers as you feel like you need to, and you tap right over that area. This is most beneficial in those patients that have I call it like a hot, angry carpal tunnel nerve, because as you tap over there, that'll reproduce their symptoms going down. If it's more chronic and they already have a lot of atrophy and weakness, their nerve may not be hot, angry, and irritated, and they may not get symptoms with Tinel. So I tend to try to use all of these if I'm suspicious of carpal tunnel syndrome. Now, carpal tunnel is still a clinical diagnosis. So just based off of the history and then the physical exam findings, that might be enough to just confirm what you're suspicious of. In some cases, though, you may want to do something like an EMG or nerve conduction study, especially if you're worried about something else that might be going on. So you're thinking, is it really from the carpal tunnel, or is it from something higher up? Is it referred from the neck? Is it a radiculopathy? Or if it's not just fitting the classic picture. And some of our hand surgeons will be fine with doing the diagnosis just based off the history and physical exam. But this study was really interesting. So this looked at a bunch of hand surgeons and looked at those that were going to proceed with surgery, and 72% used some sort of EMG or nerve conduction study before to confirm the diagnosis before proceeding with doing any sort of procedure there. If EMG isn't available, because I know the wait times can be quite long, including here at UCSF, ultrasound has been an emerging technology that's been used to look at nerves, specifically the carpal tunnel. And so the picture on the right there is an ultrasound photo of the carpal tunnel. You can see the median nerve there, and what you do is you look at the cross-sectional area. So you'll trace kind of a circle around it to look at the circumference of it. And there's different cutoffs which are debated, but I would say anything that's greater than 13 millimeters squared is considered to be abnormal and enlarged. So that can be another way that you can do it. If you have a patient that's really young, like I see pediatric patients that would not tolerate EMG or nerve conduction study, ultrasound can be an option. Or like I said, if you have a good ultrasonographer there, but EMG might be a challenging thing, and they're comfortable out looking at nerves, then you can also do something like that too. Treatment, there's a bunch of things you can try. Activity modification, I think, is what I tend to go for as the first line thing. Nighttime splinting, you may have heard of, having their wrists kind of in a neutral position is better than no treatment at all. Hand therapy, so sending them to occupational therapy to do nerve glides, different sort of strengthening exercises. And then different injections can be an option, either with steroid, which I mentioned before, or doing prolotherapy or using dextrose. And we know that ultrasound is associated with better symptom improvement in terms of using injections, although you don't have to have an ultrasound to inject the carpal tunnel. For those of you that do injections into the carpal tunnel, the easiest way to locate where you're going is by identifying the palmaris longus, which some of you can all try this. So if you bring like your thumb and pinky together and kind of flex at the wrist, you might see a little tendon. Only 80% of you will have it. So sometimes you can look at both sides if you don't have it on one side, because not all people have it, but that's the palmaris longus. And so, excuse me, your injection target will just be ulnar to that, and that's where your carpal tunnel is going to be. And then surgery is also something you can consider, but more as a last resort. So what about dextrose? I mentioned that you can use prolotherapy in certain conditions. I would say the carpal tunnel is where we have the most evidence for it. This was a systematic review and meta-analysis that looked at 4 randomized control trials where they injected dextrose and found that there was significant improvement in functional status compared to steroids within 3 months. We don't know exactly why dextrose works. We think it has some sort of impact on the inflammation of the nerve, specifically targeting a receptor called TRPV1. And it's associated with fewer adverse incidents. So for those of you that may have patients that have uncontrolled diabetes and may not be the ideal candidate for a steroid injection, dextrose injection is something that you could consider. And then there were no difference between the two treatment groups in other areas that are listed there. So it really just helps with their functional status. Okay, take a sip of water. And then we'll move on to Decker-Vein's tenosynovitis. Decker-Vein's tenosynovitis has many different names called gamer's thumb, mommy's thumb, or really we should just call it parental thumb. Or, I gained another year of age today, but this is also aging myself. I had a BlackBerry, if you remember what those were. And so when those were really popular and people were scrolling a lot, we also called it BlackBerry thumb. But people still scroll, so you can call it TikTok thumb or whatever you want to name it these days. But this is inflammation of the tendons that run through the first dorsal extensor compartment of the wrist, specifically impacting the 2 muscles that are listed there. So the adductor pollicis longus and then the extensor pollicis brevis, or the APL and EPB. And then the mnemonic that you can remember if you don't remember what these muscles are all people love eating peanut butter, which is what I had learned in med school, but never really resonated with me because I'm actually allergic to peanuts. But if that makes it easier for you to remember, then so be it. This is more common in women than men, around 40 to 60 years of age. And then we do see it in our younger folks due to smartphone use. Symptoms usually involve pain or swelling at the dorsal radial wrist. Oh my gosh, there must be something with this microphone because Dr. Luke had the same thing happen to him. So I'm going to take some water too. The symptoms can involve pain or swelling at the dorsal radial wrist. So that photo on the right shows some swelling. That might be really subtle, but if you look at the distal radius there, you can see that there's a slight prominence of the soft tissue. So that looks like Decker-Vein's tenosynovitis. Symptoms will be worse with thumb movements or repetitive lifting, hence the name parental thumb. So when they have a new child and they're lifting their child all the time, that repetitive motion can aggravate the APL and EPB. There's 2 tests that you can do for this, and they're often confused for one another. And to be quite honest with you, I was confused all the way through residency until I became a fellow in sports medicine. And I've talked to some of our hand surgeons, and this is the way I think it's supposed to be. But the general gist is what you want to do is really put them into ulnar deviation and then also ulnarly deviate the thumb, because that's putting the 2 muscle groups at max tension. So the Finkelstein's test is where you have them in ulnar deviation at the wrist, and then you passively flex the thumb down to see if it reproduces pain right over that first dorsal compartment. The Eichhoff's test is different in that you have them grasp their thumb and then ulnarly deviate down. Now, for some people, some of you are like, oh, that's kind of uncomfortable already. It is an uncomfortable test to do. But for those that have decurvatus tendinosynovitis, it's quite bothersome. So sometimes even just ulnarly deviating will reproduce a lot of their symptoms over that area. Treatment for this includes splinting. You could either use a thumb spica one that's available over the counter or a custom prefabricated one. Non-steroidal anti-inflammatories, either topical or oral. Steroid injections, and then surgery as a last resort. We know from studies that injections plus splinting have better outcomes than an injection alone or just splinting alone. And these are all injections that you can all do, but I usually do them under ultrasound. The photo on the right there is a depiction of what the first dorsal compartment looks under ultrasound, where you can see the APL and APB. And in a certain group, there's around 40% of people that have a separate subsheath. So when you look under ultrasound, you might not see them all encased in one sheath. They might be separate subsheaths that are there. The good news is that steroid injections have a pretty high success rate. So around 75% of people get better with the steroid injection. In that, we know that ultrasound can yield better symptom resolution compared to landmark-based, but I think steroids in general can be quite beneficial for this. Okay, now we'll move on to the hand, and we'll talk about stenosing flexor tendinosynovitis, which is also known as trigger finger. This is where the smooth flexion and extension of a finger is affected, and often they'll report some triggering or catching as they flex and extend their finger. This is a depiction of what our flexor tendons look like. So we have the FDS and FDP, so the flexor digitorum profundus as well as the superficialis, and they run under a series of pulleys that insert at the tip of our fingers. And we know that there can be inflammation of the either pulley or the tendon itself that causes a size discrepancy. And that inflammation or thickening, which is pictured there, causes the triggering or causes it to get stuck in certain positions. And so the way that you can think of it is there's a tunnel and something's trying to fit through the tunnel, but there's a mismatch, and so something gets stuck along the way. This impacts around 2% of the general population, but a higher incidence in those that have diabetes. The ring finger is the most common affected digit, followed by the thumb. And then diabetics can have multiple joints affected, and really anyone can, but a higher prevalence in diabetics. Symptoms can present in many different ways. They may just complain of pain in the finger. This is kind of one of those nebulous presenting diagnoses. Someone once told me when I was a trainee that if you don't know what it is, it's trigger finger until ruled out otherwise. So I always have a high suspicion for trigger finger because it presents in many different ways. They could just complain of pain on the volar aspect, kind of along like the palmar crease, either the digital palmar crease or the actual palmar crease itself. They may have crepitus with range of motion, so as they do that flexion extension, they may say it feels crunchy, or they may actually get locking or catching of their fingers. So they say, when I wake up, my finger is kind of stuck in a position, I have to unstick it or move it to get it unstuck in a certain area. There's a picture of what the stuck position looks like that they may present to you with. And on your exam, they'll have some palpable tenderness at the A1 pulley, and you may even feel a nodule. And so the photo on the far right there is showing you where those A1 pulleys are. So it's right near where that palmar crease is. So as you palpate over that little spot, some of you may even have some tenderness there, but you'll feel these little nodules kind of running through there, and that's where your A1 pulley is. If you feel that they have tenderness there, often what I'll do is I'll have them either actively flex or I'll passively flex their finger to see if I can sense any of that crepitus, or you may even see them lock or trigger as they do that motion. Treatment's similar to all the other conditions: rest or activity modification, non-steroidal anti-inflammatories. Splinting is an option for you, and there's a depiction of the different types of splints. These ones you can kind of move around to different fingers, and it really prevents the finger from flexing or being in that flex position. Followed by injections and then surgery. For injections, you are supposed to target around where that A1 pulley is, but as long as you get it into that flexor tendon sheath, that's all that really matters. This has a pretty high success rate. So this systematic review looked at 4 RCTs and found that it was around 60% effective, but may not be as impactful in those that have diabetes. This study looked at the efficacy of steroid injections over a period of time. So for people that got one injection, there's around 30% that had improvement. And And if they didn't have improvement and they got another one, around 60% of those had improvement. So, and then beyond that, the third one, around 66%. So my rule of thumb is I usually will try at least 2 injections, and then if it doesn't help after that much longer, then I ship them off to our hand surgeons to do a procedure. And interestingly, we think that it's more beneficial in the thumb compared to other digits. This was another study that looked at the long-term efficacy for injections and found that around 70%, so similar to the other study, had complete remission after steroid injections, higher efficacy in the thumbs compared to the other digits, and then not as effective in those with diabetes compared to those without. But I think all around, still a good option for you to think about if someone's presenting with symptoms of trigger finger. All right, well, great, we made it. So those were the top 5 things that I wanted to talk about, and there's many, many more. So if you have questions, happy to answer them in the Q&A. And what we'll move on to next, I think, is the live on-screen portion. So there's my references, and we will have our model come on. Yeah. You can just sit at the edge, or wherever's comfortable for you. Let's see. Where should we go? Anywhere? Is this sturdy enough for you to sit at the edge? Okay, you want to sit at the edge up front? All right, and I have until what time, Danny?
About 13 minutes.
Perfect, all right. So with any upper extremity physical exam or any patient presenting with an upper extremity thing, I'm always want to rule out some sort of radiculopathy or something that's coming higher up. So I'll ask questions about it. And if I do have some concerns, I'll always start with a quick cervical spine exam. So looking at like neck range of motion and even doing a Sperling's. The other thing that I'll do is I'll also look at their shoulder, specifically their shoulder range of motion, because sometimes what I see is there's patients, especially athletes that are coming in, that have symptoms of either lateral or medial epicondylopathy. And while it may be related to whatever occupation they have or sport that they're playing, sometimes, especially if they're an overhead athlete, they may have more limited internal rotation. And so as they're throwing, for example, if they have limited internal rotation, they compensate a lot by using their forearm flexors or extenders. So no matter how much PT that they're going to do for their forearm muscles, if you don't correct that internal rotation and think about the biomechanics, you're going to kind of be in the same position. So for neck range of motion, it's really quick. I have them look down, look up, look left and right, and then ear to shoulder, ear to shoulder. You can palpate or do a Sperling's, which can look for radiculopathy. And then for the shoulder range of motion, you can check that in many different ways, obviously flexion, abduction. And then I look at specifically external rotation going this way, and then internal rotation going this way when they're at 90 degrees. And what you'll see with some athletes is they'll have an internal rotation deficit. So you might see photos of baseball pitchers that look like Gumby. That reference is also dating me because I tell some of my pediatric patients, you know who Gumby is? They're like, huh, what are you talking about? But they have really great external rotation. They can get their arm way back, but then internal rotation, they're really stuck. And you can compare to their opposite side to see if it's similar or different. But if that's the case, then I'll have them work on shoulder range of motion too, because that might be contributing to the overload of their wrist extensors or flexors. Beyond that, the first thing I do, just like Dr. Luke, is inspection, range of motion, palpation, and then special tests. So inspection, you can take a look at either if there's any gross deformity. So I mentioned that olecranon bursitis, for example, might have a big prominence right on that olecranon on the elbow there. So you can get a lot just from inspection alone. Or looking for any of that muscle atrophy that I mentioned, especially at that carpal tunnel. So inspection is a key thing to take a look at. And then range of motion, I start with the elbow, and the elbow is pretty straightforward. So for the elbow, I have them, can you touch your shoulders? So that's elbow flexion. And then can you extend your hands all the way out? That's elbow extension. So you've already done your elbow range of motion. After that, what I'll do though is I'll also look at pronation and supination. So for this, I'll have them keep their elbows at their side, and then you can start like this actually, Alex, yeah, good. And then palms up, and then palms down. Great, so that's supination, and then pronation. Now, one thing to be mindful of is our patients love to show off as much as they can to us as the most range of motion they can do, so they often like to cheat. So for this, what they'll do is if they have limited, let's say, supination, as they try to bring their hand up, they're gonna swoop their arm underneath them. So that's why I'm really mindful of them keeping their elbows out their side so they're not cheating. So keeping them there, so palms up and palms down. After that, you could check ulnar and radial deviation of the wrist. So from here, I just have them bring their hands up and have them wave at me back and forth. So you're looking at ulnar and radial deviation, okay? And you can bring it back down. And then for wrist extension and flexion, I have them go into like the namaste position. So that's wrist extension, and then flexion, you just do palms down. Perfect. So now you've done all the range of motion of the upper extremity. So we've done flexion, extension, pronation, supination, ulnar and radial deviation. And then we've also done the flexion, extension. And then you can just have them flex the hands. So then you do gripping too. So you can make sure that all those are intact. Now, depending on what I'm suspicious of, as Dr. Luke mentioned, don't forget motor sensory DTR. We won't go into that. We'll focus on some of the other things, but I think that's a key part of your exam that you shouldn't neglect. After that, we'll start maybe at the elbow first, and let's see, it might be, is it easier on this side, do you think? Okay. So I'll sit back here. Perfect. So for the elbow, we'll start with the lateral epicondyle. So I kind of mentioned this before, but that's a big bony prominence that's on the lateral side. It's pretty easy to palpate, and you can all practice palpating on yourselves as you're sitting there. If you're worried that you're not really over the right spot, you can have them extend their wrists, and I can feel those wrist extensors here running and inserting right onto that lateral epicondyle that's there, okay? And then for the Cosen's test for lateral epicondylopathy, it's really that motion. So I have you bring your elbow out, good, and then extend your wrist up. And then oftentimes just that alone will be enough to provoke the symptoms right over that area. If it's not, then you can do some resisted wrist extension. So I say, keep it up there and don't let me move, and you pull. And so you're resisting to see if they have pain right over that spot. We'll shift over, I'll move over to this side, to the medial side of the elbow. The medial epicondyle is right over that bony prominence on the medial side. Again, if you're having trouble palpating where that is, you can have them make a fist and then flex. And then you can, I wasn't on the right spot initially, but now I can feel where it is. So it's right over that little area that's there. So right over that spot. Same thing, that motion might provoke their symptoms, or you can resist them when they're in that motion and see if that can make it more bothersome for them. And that's right over that little spot. If you swoop your fingers just posterior to that, you'll get into this little groove here, and I think there's a shadow. It might be hard to see. Sorry, I'm twisting your elbow around. So this is the medial epicondyle right here. And then my finger will go into this little soft spot that feels like a tunnel, and that's that cubital tunnel. So that's where that ulnar nerve lives. So there's several tests that you can do. So just tapping, you can do like a Tinel's there if you're worried about someone having like cubital tunnel syndrome, and that might produce symptoms going into their pinky or ring finger. And then as you flex and extend, you can also see if they have a subluxing ulnar nerve. So some of you may feel your own ulnar nerve sublux over that area. For those of you that are in the physical exam breakout that I'm leading later, you can all feel my subluxing ulnar nerves because I have some good ones on both sides. But that is something that you might palpate as well. That can be aggravating for patients. And then the olecranon is the big bony prominence on the back. So that's what we classically think of as being our elbow. It's right over that olecranon. So you can also palpate there. And then just above it is where so here I'll show on this one, sorry. So olecranon here, and then just above it is where the triceps run and insert right onto that little area there too. So that's the main part of the things that I talked about in the elbow. Moving down into the wrist area, there's several things that you can palpate. On the dorsal aspect, I like to just palpate starting kind of in the mid-forearm area, going all the way down. And I like to be systematic, so I'll go more radial and then ulnar. So I palpate kind of along that area to see if they have any tenderness, specifically over the radial shaft going down into the distal radius. And then as you get down to the distal radius, you might feel a little bump that's here. That's called Lister's tubercle. So that's an important landmark when we're thinking about doing things like ultrasound or just knowing where that is to help you identify other bony landmarks. Lister's tubercle, let's see, can you make a fist? Maybe it's this little bony prominence kind of right over that little spot there. So from Lister tubercle, if you just go distal to that, then you're kind of in what we call the SL area. That's where the scaphoid and the lunate meet, and there's a ligament there. And then if you go radial to that, then you're kind of getting close to what we call the anatomical snuff box, and that's where the scaphoid is. So if you kind of lift your thumb, oh, perfect. So do you see, let's see, right in here. So this is where the APL and EPB kind of run like in this little area. So that's where people will have de Quervain's tenosynovitis. This is your extensor pollicis longus as it goes around the Lister's tubercle. And then this little gap in between is called your snuff box. And if you palpate in that area, that's where the scaphoid is. So if you're worried that someone has tenderness there, I would get a scaphoid view x-ray to take a look to see if they have a fracture. And then from here, we can talk about de Quervain's tenosynovitis, which impacts that first dorsal compartment. And for that, there's those two different tests I talked about. There's Eichhoff's test and Finkelstein's. So one is you just ulnarly deviate them, and then you passively flex their thumb to see if they have pain along that area. And then the opposite one you can do, or the other one, is you have them just grasp their thumb and then ulnarly deviate to see if they get pain over that spot. This is where you may see that swelling, like I showed on the photo, if they do have any de Quervain's tenosynovitis. We'll move on to the ulnar side of the dorsal aspect. So as you palpate along that area, same thing, palpating along the bony shaft and then down to the ulnar styloid. On the ulnar side, there's not a whole lot of things that I typically think about. Oh, we'll switch to this side. So the ulnar side down to the ulnar styloid. There, as you go to the ulnar styloid, you'll feel this little dip in here. This is where something that's called your TFCC, or your triangular fibrocartilage complex, lives, and people can get tears of their TFCC. There's a little fovea here that you can palpate into, so if they have tenderness right into that little area, makes you think that they might have some sort of TFCC thing going on. There's also the ECU that runs along this area, and so they can get ECU tendonitis or tendinopathy along the ulnar side. We'll move on to the volar aspect now. And then the carpal tunnel is actually a little more distal than I used to think when I was a trainee, like in med school. I used to think it was right here at the wrist, but it's actually more distal. So it's kind of right over this little area between the, like if you have them make the L, here we'll show them how you do the L. Maybe do it on this side so that they can see. Make an L, perfect. So that's where you're looking at that like fatty thenar muscle that's there to see if there's any atrophy, or the bulk of the muscle to see if there's any atrophy. And then the carpal tunnel is kind of right in between the hypothenar and thenar eminence, so right over that spot. So Durkin's compression test, you're just compressing right over that area to see if they get reproduction of their symptoms, again, holding it for about 60 seconds. Tinell's, you're tapping over that spot to see if you get reproduction of symptoms. And then Phelan's test is where you just have them with their wrist flex, elbow extended, holding that for 60 seconds to see if they get reproduction of symptoms. From the volar side, you can also palpate the scaphoid tubercle. So if you go just towards that thenar eminence, you can feel the bony prominence there. That's scaphoid, that's the tubercle. So if you're worried about a scaphoid fracture, you should palpate in multiple areas, both on the volar and the dorsal side. And then finally, we'll talk about the trigger finger, or the synosine flexor tenosynovitis. So if you look here, you can see that there's the palmar crease kind of right in this area. And then if you push over these little spots, you can feel these little nodules over that. So that's where the A1 pulley is. So let's say that there was tenderness over the ring finger here. So I'll palpate there, and then I'll say, can you flex and extend? So you can see there's no triggering, which is good. But you can also passively do it to see if there's any crepitus or triggering over that spot. And then I usually will inject just a little distal to that. So, I'll palpate kind of right over that area and then inject into that flexor tendon sheath if I'm concerned about any sort of trigger finger, and often that's pretty alleviating for our patients. That's the exam, I think, for the stuff that we talked about. I want to be mindful of the time, but happy to answer any questions, and thanks to our wonderful model for being a hand model for us today.
Hi, thanks for a great talk. I'm curious with the splinting for trigger finger, kind of what you can expect out of it. Is it just symptom control? Can it let the inflammation go down if you do it, with enough frequency to where you don't need an injection? I guess I was kind of taught that it didn't do much.
Yeah, you're right. I think it depends on the patient's compliance of using it, like anything else. And there's two types of splints that are out there. There's ones that limit motion more at like the base part here, and then there's ones that limit motion further down or distally. I usually tell them to try to wear it just when they're sleeping at night because often they're sleeping with clenched fists to see if that's enough. But our hand surgeons, some of them say they have to wear it pretty continuously for several weeks to notice any benefit from it. And that can be really tough depending on their lifestyle and what they're doing. I think it's pretty low-hanging fruit, though, for them to try. And if they do get relief from it, great. If not, then you can give them a steroid injection, and we saw that it can be quite beneficial for them. Yeah.
So I think you were suggesting during the exam that the trigger finger effect can happen in any of the fingers?
That's correct, yep.
And same treatment, right?
Correct, yep. Same treatment for any of them, yeah. There's one up here, Danny.
Thanks. So you mentioned during your talk that for deeper gains, there is a benefit to doing the injection and splinting over either one alone. Is your practice to do both of those immediately when you see a patient? And in my practice, I've been typically like splinting them first, and then if it's not getting better in a month, then come back to the injection. What do you do?
Yeah, I do a hybrid, and I try to really meet my patient wherever they're at. And often by the time they've seen me, to be honest, they're ready to get an injection because they've tried everything else. So we'll go ahead and do that. If they find that the splint isn't too disruptive to their life, then they can try wearing that for a period of time after. I tell them that the injection we know helps. We know that splinting can help, but both of them together is better than either of them alone. And if they choose to do it, great. If they don't, they'll probably still get better from the steroid injection. Yeah.
I work in a different university system, so it may be different, but where I am, I've been sending these kind of patients with hand and wrist pains to hand clinic. Would it be better to send them to sports medicine so they could see someone like you first? If they don't obviously need surgery.
Yeah, I think it depends on your health system. Everywhere is different. And the reason why I presented the conditions that I did is because I think these are all things that you can treat in your primary care clinic quite well. You don't need to actually refer them to a specialist until they're ready, you think, to get surgery. So you can do the injection, you can do the splinting and the therapy, and then if they still have refractory symptoms, they're packaged up nicely to go to a hand surgeon, and by then they're probably ready to get some sort of procedure done. So I think it depends how far along they are. Like if they've had injections already, probably not the best thing for me to be seen in my sports clinic because I'll probably just send them to the hand surgeon. But if they haven't and they're interested in that, I think either one's fine depending on the availability and who your primary care sports providers see. In primary care sports, we can see everything, which is nice. But each health system is very different in terms of how the referral process works. So I would just look at that and see, first and foremost, what your primary care sports team does at your university or clinic, and then what that referral flow is kind of like.
Okay, hold on.
Got to get your exercise, Danny.
I know you didn't really touch on it in your talk, but I was wondering what treatment modalities you found are effective for cubital tunnel syndrome, because I feel like I do see a fair amount of it, and like when I try and research it, it seems like there's not a ton that is super efficacious.
Yeah, there's not a lot. So cubital tunnel is where you get ulnar neuropathy symptoms that happen at the cubital tunnel that I mentioned. That's where the funny bone is. So they'll get symptoms going into the ring and pinky finger. We see it a lot more now, I would say, because of screen use. So like iPads or Kindles, especially reading at night. So anything that involves their arms being flexed. I mentioned my ulnar nerve subluxed over my medial epicondyle there. So I also get some intermittent symptoms. And really it's about trying to modify those activities that may provoke those. So if they're reading at night and their arms are flexed, telling them maybe to have a stand or something so that they can keep their elbows extended. There are braces that you can use when you're sleeping at night. They look like knee pads and you flip it around so that it keeps their arm in extension. And then you can try different injections towards that area or nerve hydrodissections. But if it's subluxing, it's really about trying to prevent that motion. And then in some cases, you send them to surgery, and then they either do, it depends on what they have, but sometimes have to transpose the nerve over and pin it down too. So it kind of depends, yeah. But you're right, there's not a lot of great options besides trying to modify those activities. Yeah.
Hi, this question is about PRP and tenotomy for your patients with lateral epicondylitis who do go on to that. How soon after the treatment do you begin their rehab program with eccentric strengthening? And do you allow for activities as tolerated, or do you have a period where you might put them in a little bit of a brace after the procedure?
Yeah, PRP for tendons, I think Dr. Berrigan's talk will be very helpful because he can dive a lot deeper into that. There's no consensus on the rehab protocol for it, but we do know that tendons take a little bit longer to heal compared to a joint, for example. So for eccentrics, to answer your question, that's usually much later on. So for tendons, we really have them reserve that until the post-injection, like 6 to 8 week mark. Some people do elect, depending on where the injection was, to have them in some sort of offloading device for a period of time, and then gradually ramp up their activities after that. Yeah.
So you talked about equivalence, but there's also this distal intersection syndrome and proximal intersection syndrome because of video game controllers. So just a little bit of your thoughts on that.
Yeah, that's a good point. That is something you should keep in your differential. I think that decrepifrant tenosynovitis is the most common, which I talked about it, but you're alluding to intersection syndrome. So intersection syndrome there's two forms, as you mentioned, distal and proximal. Distal intersection syndrome, or both of them, are basically where the extensor compartments are crossing over, and you can get inflammation or even like subluxing of each other as they do that. So the proximal intersection syndrome is usually the first and second extensor compartments, and then the distal is the second and third that happens. That's where I'm lucky as a primary care sports physician. I can throw an ultrasound on to take a look and see what is really the cause of their symptoms. So is it really that first dorsal compartment, or is it something else that's going higher up? Often they'll complain, especially for proximal intersection syndrome, of symptoms that are more proximal over that little area. But you're right, it can be a confounder and challenging when you're thinking about patients that play games, for example, as you mentioned, that have pain kind of over that thumb area. The treatment would be very similar, it's just the injection would target a different area, yeah.
All right, Nick, I'm gonna do one from the app and then if there's one.
Okay.
So most of my athletes will go by a one-size-fits-all for their baseball bats and tennis rackets, for example. Despite varying hand and finger sizes, what are some tips to improve proper fitting for grip, specifically for reducing risk or severity of lateral epicondylolgia?
Oh, yeah, that's a loaded question. I think that there's no great answer for that. I think it's really about, one, if they're coming to you with symptoms, I think if you have the time to dig into the history to see what sort of bat they're using, and perhaps if the size is too big for them, then trying to have them modify it. Depending on your clinic setting, unfortunately, a lot of kids, or fortunately, have coaches for everything these days because they're hyper-specialized in certain areas, which we know isn't the best thing. So plug for Dr. Pandya's talk that's going to talk about sports specialization in youth athletes. But I think that you can have them work with whatever coach they have to find a better suited bat or equipment for them that is helpful for whatever size they're at. But I think counseling them and their parent that this is something that is related to an equipment thing or their biomechanics in and of itself is valuable, because sometimes that's all they need to hear, and sometimes it just has to come from their healthcare provider rather than their coach or their teammate, or the kid hearing it from a doctor rather than their parent, even if we say the same thing, because we all know that kids don't listen to their parents. So.
On that note, would you say it's more of a grip issue or more of a frequency and load issue?
Ooh, it's probably more the frequency and load, to be honest, but it's the frequency and load combined with the equipment too that makes it extra loaded, for lack of a better term.
Could you explain the splints you're talking about for the lateral epicondylitis?
Oh, yeah, sure. So the counterforce splint is basically a compressive device that they put just distal to that lateral epicondyle. And the idea is it's similar to those patellar tendon straps, is it redirects that force vector as the muscle or tendon runs and inserts onto that area. The caveat I will say is that patients will try to put that on as tight as they can sometimes, which as we know, isn't the best thing. And sometimes that can aggravate the radial nerve as it goes to that radial tunnel. So their elbow might feel better, but then their forearm will start hurting. And that's because of the counterforce brace that they're using. And then the other thing that people try is just a wrist brace that stabilizes the wrist and prevents it from going into wrist extension, because it's the wrist extensors that cause lateral epicondylopathy as it inserts onto that lateral epicondyle. So if you can prevent that motion, then that can be beneficial.
All right, we're out of time, but thank you, Dr. Hatamiya, for a great talk.
It was always 20. All right, we're going to take a short break. Guys, get a 10-minute break. Go grab a snack, use the restroom, get some water, and then we'll continue with Dr. Brian Cooley after this.